Hi, everyone. Welcome to the Lancet series, webinar series on public policy and health in the USA. Today's topic is, should investors own healthcare? My name is Dan Erkes. I'm a senior editor with the Lancet, and I'll be introducing our moderator shortly. Just some housekeeping points. Attendees are welcome to submit questions throughout the presentation. Use the Ask button box on the dashboard. There's a little picture of it. On the webinar dashboard, you will see the box with related resources. A link to related Lancet content is featured and will take you to thelancet.com. You can also adjust or minimize any of the boxes that appear on the webinar dashboard to suit your preferences. A link to the on-demand version of the webinar will be emailed to all once the event has concluded. Once the webinar is ended, please complete our 30-second feedback survey so that we can continue to improve our webinar offerings. And with that, I'm going to introduce our moderator, Claudia Fegan, Chief Medical Officer, Cook County Health System, USA.
Thank you very much. Welcome, everyone. I'm the Chief Medical Officer for Cook County Health and the National Coordinator of Physicians for a National Health Program. We have an exciting program, I think a very important discussion. We're going to have Don Berwick, the former administrator for the Center for Medicaid and Medicare, the past president of Institute for Healthcare Improvement, a clinical professor of pediatrics and healthcare policy at Harvard Medical School, and a nationally acclaimed for his work in healthcare quality. Rosemary Bott is the Alice Hanson Cook Professor of Women and Work at Cornell University School of Industrial and Labor Relations. She has published widely on comparative international studies of management and employment relations. She has focused on the impact of the financialization of management and employment and the globalization and restructuring of service industries and its impact on low-wage workers. Steffi Woolhandler is one of the co-founders of Physicians for a National Health Program. She is a distinguished professor of public health and health policy at CUNY and School of Public Health at Hunter College, as well as adjunct clinical professor at Albert Einstein College of Medicine, as well as a lecturer at Harvard Medical School. She is nationally recognized expert on the inadequacies of the current U.S. healthcare system, and she is co-chair of the Lancet Commission on Public Policy and Health. The question of should investors own healthcare, I believe, is the most important policy issue facing healthcare in the United States today. We spend over $4 trillion a year. 18% of our gross domestic product is spent on healthcare in the U.S. each year. That is more than twice as much as most other developed countries. Yet we rank miserably in the outcome measures such as life expectancy, preventable hospitalizations, maternal mortality, and suicide. We need to ask what role the current U.S. investor-driven healthcare system plays in causing and exacerbating the racial disparities in healthcare. Increasingly, we are seeing large health systems closing or reducing health services in poor areas while building new or expanding services in wealthy areas. We are starting to see healthcare deserts where patients must drive miles, even in urban areas, to find providers, or, for example, a hospital that offers obstetrical services. While the life expectancy for whites decreased by 2.4 years during the pandemic, it decreased by more than 4 years for Blacks and Hispanics. The maternal mortality rate for non-Hispanic Black women is 2.6 times the rate for non-Hispanic white women. Black youth have the fastest rising suicide rate compared to their peers of other races, and for the first time in history have surpassed the rate among white teens. Consolidation of hospitals, insurers, and medical practices, which accelerated during the pandemic, leaves more and more patients behind. Consolidation increases healthcare costs and increases insurance premiums. The higher the cost of care, the more people who become underinsured and uninsured. Medical illnesses and medical debt are the #1 causes of bankruptcy in the U.S. Higher insurance premiums lead to wage stagnation for workers with employment-based insurance. Employers who have to pay higher premiums are less willing to raise wages. Health insurance companies discourage care to hold down costs. They put in place obstacles that delay procedures, such as prior authorization, that sometimes results in the denial of indicated treatments. They restrict the use of expensive medications and tests until justification can be made to their satisfaction. Sometimes, care delayed becomes care denied. At the same time, the U.S. healthcare system perpetuates incentives for therapies with higher margins and specialties as opposed to primary care, preventive care, and public health. Our higher pay for procedures and specialists discourages young people to consider careers in primary care and public health, which has resulted in woeful shortages of the providers we need the most. What became painfully apparent during the pandemic, as the country has spent more and more on healthcare, we have spent less and less on public health infrastructure. When COVID struck, we no longer had the resources to protect the public. We lacked the ability to do contact tracing, the resources to safely isolate those infected, and the staff to stand up mass vaccination centers when a vaccine became available. More people died as a result. Investor-driven decisions are directed toward enhancing profits and wealth rather than enhancing access to healthcare for all patients. The delivery of healthcare should not be the driver of excessive private gain, should not be the source for increasing numbers of millionaires and billionaires, while the numbers of preventable deaths increase each year. Don Berwick reminds us that greed concentrates wealth, and wealth concentrates political power, and political power blocks constraints on greed. And with that, I'd like to turn it over to Dr. Donald Berwick.
Thank you so much, Claudia, and it's such an honor to join you and Rose and Steffi, three advocates and scholars whose work I admire immensely. You just said it all, Claudia, and I'm thinking maybe we should just move direct to Rosemary, who actually has the data, but I'm really going to be mostly repeating what you said in slightly different words. We have a crisis here, but it's a very, very deeply embedded one, and I don't know how to change the dynamics. I congratulate the Lancet in raising the visibility of the issues we're going to be talking about now. We live in a time of paradox. My own wife, Anne, who is getting along in years, is an athlete. She's hiked and swum and been very vigorous her whole life. Last year, she suddenly couldn't do it. She was weak and couldn't walk across a room. We realized it was congestive heart failure because her pacemaker wire had destroyed her tricuspid valve. And so she had to go into the hospital quite urgently to have a tricuspid valve replacement. As I'm talking to you today, less than a year later, Anne is currently on a 20-mile bicycle ride, which I wish I could join her on through the mountains here in New Hampshire. Miracles. And I must say the performance of the team that did the surgery and helped her through this journey was deeply inspiring. Cooperation, teamwork, dedication to patient needs. And that's just a small example of the miracles that we can produce with our care system. But underneath that really wonderful story, we find a system that is deeply, deeply distressed right now. I cannot tell you the number of meetings and conferences and commissions I've been on now trying to deal with worker burnout, with this sense of demoralization and shortages, doctors talking about leaving the profession at rates we've never seen before, and vacancy rates to match that. Really a profession that's become sad about the most privileged kind of work we can ever do: doctors, nurses, pharmacists, and managers in healthcare. We have patients who are bewildered, more and more out-of-pocket payment at a time when people, especially people of lower income, are having trouble making ends meet. And the number one cause of that debt, as you said, Claudia, is medical debt, and costs soar. While we watch other countries have mortality rates much lower than ours, longevity much longer than ours, and us spending nearly double the amount of money of the average in the OECD countries, underperforming in health and well-being, our costs are double. something is really wrong. The stress of the pandemic only highlighted these issues. Now, there's no simple explanation for why this is the case. I'll get in the end to what I think may be at the heart of it. But I have become convinced in the past few years, as I've tried to understand how such a noble system can be so underperforming its potential at the cost of the well-being and spirit of the workforce and the patients it serves, I have come to use the word greed. And I've been challenged for that because most of the people go to work every day in all sectors of healthcare, feel quite good about what they're doing. They're trying to help patients. But if we look at the underlying dynamics, I believe the commoditization, commercialization, the role of changing ownership to private hands, and the proletarianization of the healthcare workforce lie at the core of at least some of the reasons why this system is so deeply underperforming, to the special disadvantage of marginalized and disadvantaged populations and people of color. You cannot find a sector in healthcare in which greed is not just manifest, but I would claim even dominant. The target we most read about is the pharmaceutical industry. Now, again, a paradox. We have a lot to thank about what the pharmaceutical industry has done over the years to create possibilities that weren't there before. We could now eradicate hepatitis C from our nation, as Francis Collins has claimed, and President Biden, I believe, will embrace, and that's done through breakthroughs in drugs. We can do things for HIV/AIDS and the rapid development of the vaccines that have, for now at least, controlled the pandemic. All are testimony to the enormous power of science in the hands of pharmaceutical development. But it should not pass notice that a great deal of that progress came from government investment, the underlying sciences and incentives that were offered to the industry. But beyond that, if you look at what the pharmaceutical industry harvests in profit and the prices that are passed through to our entire population, it's eye-watering. And people in other nations who watch what happens to our pharmaceutical prices simply do not understand it. They don't understand how that can happen. Kaiser Health News reported a story last year of a patient charged $73,800 at the University of Chicago for 2 injections of Lupron Depot. $73,000 for that treatment for prostate cancer. That's a drug available in the United Kingdom for $260 a dose. Pharmaceutical prices are out of control. And the pharma industry has developed a level of influence on Congress and ability to control efforts to limit pricing that has dominated. Now, recent legislation, as you know, has given CMS the chance to negotiate drug prices for 10 drugs. That doesn't kick in until 2026, and it's a very small start, really, for what we need to do to get American pharmaceutical prices back in the box. The pharma industry claims that this is the price we pay for their innovations. I don't have time in 13 minutes to explain why that is a flawed and ill-founded claim based on the evidence. Insurance companies. We now have a high degree of private insurance, starting with Medicare, which was a public insurance program that now more than 50% of Medicare beneficiaries are members of the private side of Medicare. Medicare Advantage, which was started as an experiment to try to get the benefits of good managed care to Medicare beneficiaries, now is a completely out of control arena for profiteering and enormous overpricing. The way this is accomplished is, again, too technical for the time we have, but one of the key ways is upcoding. Medicare Advantage plans rewarding doctors or themselves placing nurses in homes or using electronic media to add codes to patient diagnoses, to patient records that have nothing to do with their care and will not all affect their outcomes. And yet with those codes comes extra money from the government to the tune, according to my colleague Richard Cronick, who's done research on this particular issue, of $600 billion of excess payment to Medicare Advantage over the next 8 years. The privatization of Medicare is leading to a hemorrhage of public dollars into private pockets, producing levels of profit, levels of executive compensation, levels of stock buybacks that make no sense from the viewpoint of public investment in the public's health. And that's not the only game played. My own doctor reported when a private firm bought the practice that gives me primary care, that suddenly all of his patients, Medicare patients with atrial fibrillation, suddenly had a new diagnosis added, hypercoagulable state. Now, hypercoagulable state is true of most people with atrial fibrillation. Most people with atrial fibrillation are already on anticoagulants. It has nothing to do with the needs of the patient, but only with payment, because add that code to a patient's record and you get paid, I think, close to $3,000 extra a year. It's the largest transfer of public money to private hands and profit that I know of in the current economy. Hospitals have not escaped the seduction of profiteering and greed. Hospital consolidation, as you mentioned, hospital pricing soaring without any real attempt to constrain those prices into reasonable terms or terms that match other terms in other countries. My own brother had surgery a couple of weeks ago, and he called me to tell me the story that he got his bill, and he remembers he was asked to bring his own CPAP to the hospital because he knew how to use it. During his hospitalization, a pulmonologist, a lung doctor, stopped by the room for 15 seconds twice, in both occasions, to say to my brother, "You're on your own CPAP? Yep. Everything okay? Yep." And he walked out. On the bill, $880 per visit by the pulmonologist. The hospitals in some way are playing the same kind of pricing games that that we accuse the insurance companies of playing when they play in the Medicare Advantage world. This is largely being accomplished by mergers and acquisitions, which are claimed to reduce costs, but demonstrably do not. The physicians are not completely immune to the consequences of this pursuit of greed, and we have pricing behaviors on the part of physician groups that also drain the public treasury. I won't go more into that. You already, Claudia, mentioned the consequences of this for the public. In the United States now, we have over, I think, 110 million people in medical debt, 41% of the population. No other country, no other developed country in the world has anything close to that. No other country understands that. One of the, by far, largest causes of bankruptcy in our nation, and the shorter bankruptcy, the increasing load on patients and families and out-of-pocket costs has just gone up and up and up. So this pricing and profiteering comes out of the pockets, not just of the government and taxpayers, but of individual patients. I used to be, until recently, on the Massachusetts Health Policy Commission, in a wealthy state with a good healthcare system. But the Health Policy Commission reported that the rate of medical costs in the Commonwealth rose at 4 times the rate of inflation over the past 10 years. This is played out through mergers and acquisitions and games in the executive suite. Bloomberg Media in 2020 listed the 10 highest paid executives in America, not the 10 highest paid healthcare executives, the 10 highest paid executives. 3 of the 10 were from a single healthcare system, Oak Street Health, which was an innovative primary care company, which does good work. But in Oak Street, the CEO that year in total compensation, according to Bloomberg, got $568 million. The COO, $356 million. The CMO got $221 million. It's confiscatory behavior in a system which allows greed to play out. Now, we will hear more from Rosemary and about the way in which this kind of gaming occurs, but let us not underestimate the effect of this on the individual patient and family, not just people of lowest income, but people throughout the income spectrum. I have a friend whose sister was making a trip to South America with her 2 kids, went to a pediatric infectious disease clinic in a New York City hospital, and the insurance company notified her that she owed a total of $8,477 for 2 shots for 3 kids. at the San Francisco Department of Health, the public Department of Health, that bill would have been $150. There is suffering as a result. Now, if we trace this back to my opening remarks on demoralization of the healthcare workforce, on CEOs who feel confused about their mission, on patients who wonder what is happening in the financial side of healthcare, I think we have to trace a great deal of that back to this profiteering, greed, and excess. Could we control it? Of course we could control it. We've found many ways through American history to take out of control profiteering behaviors and bring them under control. But then there's the cycle that you quoted that I wrote about, Claudia. Greed right now effectively concentrates wealth in the United States. Wealth concentrates political power and influence through the role of lobbying and political contribution. And that political influence stops efforts to rein in or place constraints on greed. How we get out of this cycle, I'm not sure. I think underneath it, as I said when I started, is a deeper problem, which is the myth of markets as a generator of well-being in what is essentially a common good and a human right. Naomi Oreskes, the wonderful historian, has just written a book called The Big Myth. And it's about how we have all bought an empirically wrong theory that if we make the market work properly, these inadequacies, gaps, inequities, and excess will be controlled. If we've learned anything now in half century of healthcare finance and delivery, that is not a solution. The healthcare system has escaped from constraints, allowing individuals and private interests of enormous power to gain the reins, to line their pockets, and to take money, resource, and opportunity out of the pockets and opportunities for government, for individuals, and especially for the least advantaged among us. That's my comment, Claudia. I look forward to the conversation after my colleagues speak.
Thank you. And we'll go right to Rosemary Bott, please.
Okay. I want to get to my slides. And first of all, thank you so much to the Lancet for inviting me to be part of this esteemed panel. Don, your comments are amazing and powerful, and I hope that I can follow with some details on the role of private equity in shaping financialization and excess wealth extraction in healthcare. I want to start by saying that my work in this area is all done with Eileen Applebaum, who is the director of the Center for Economic and Policy Research at in Washington, D.C. And in this paper, the presentation, I'm going to first lay out the private equity business model, show why it is fundamentally wrong for healthcare, provide a few basic examples of the negative outcomes as a result, and then move to implications for global healthcare as well. So first of all, the private equity business model. The fundamentals are that the private equity firm creates an investment fund and raises money from pension funds, institutional investors, wealthy individuals for a 10-year commitment that they must make. The private equity firm itself invests less than 2% in the investment fund of their own money, and they receive 2% annual fees plus 20% returns on profit. Now, what that means is that right off the top, 2% times 20 or 10 means that $20 million off the top of, say, a $100 million fund goes directly to the private equity firm, and they do not have to expense for it or account for it in any way. They also then take risks with other people's money, and they have few downside risks, but they have upside gains of disproportionately sharing in the 20% of the returns. Then they do things that are fundamentally different from publicly traded for-profits. I want to emphasize that private equity is a different type of investor. They promise their investors outsized returns that substantially beat the stock market. And so in order to do so, they used a leveraged buyout model, which means that they buy out companies and load the companies with excessive debt. They use excessive debt because it multiplies their returns on profits. But the portfolio companies, or in this case, the healthcare providers, are loaded with the debt, which leads them to have more financial instability. They exit the portfolio usually within a 5-year window. They need to flip it in order to take out money and return proceeds to their investors in a short period of time because they want to go on and raise another investment fund. They have little or no oversight by the Securities and Exchange Commission, and they are viewed by law as passive investors, which means that even though they are calling all the shots in the strategic decisions regarding the companies they own, they are viewed as passive. And so anything that goes wrong is blamed on the company, not on the private equity firm. And they are also hidden from view, so they don't suffer the reputational effects as those are loaded on the portfolio provider. Okay, then let's look at the growth of private equity. It's been huge. So from 2000 till now, it has grown 25-fold in some 20 years. It started out with about 100 deals per year in buying out companies. Now they are up to almost 1,400 deals. And the amount of money in the deals is about 140 billion a year. So they're a substantial player, even though they're not numerically dominant. They have a large influence over many providers. So now let's look at how it's penetrated. It has penetrated virtually every segment of healthcare: hospitals, physicians, specialties, nursing homes, outpatient, and particularly now it is viewing home health, hospice, and mental health as hot markets because there's a lot of money there given the problems in those markets. If we go further, how does private equity change healthcare? And this is what I want to emphasize and draw on what Don said. So it turns healthcare from a social good into a financial asset to be bought and sold. And you might think of it as Lego chips. So here we have a hospital or nursing home before, and this is what it looks like afterwards. In other words, private equity firm partners do due diligence to figure out which are the pieces of the market or the segments that are most lucrative, and they hive them off to buy them and sell them and make money. And so what this means is that it extracts wealth through financial strategies and not primarily by providing better care. There may be some improvements in care, but the fundamental focus is on financial gain. Then we look at how does private equity make money and who pays the cost. So here I want to move into some examples of their financial engineering strategies. First, they buy out a healthcare provider using substantial debt. I've talked about that. And they use then the money to build a national chain by buying out several providers and create a national chain that may have monopoly power. They are responsible for some 45% of current merger and acquisition activity, even though they are a much smaller player in the market. They then extract outsized returns through typical things like cost cutting and shortage on supplies and services. Sale leasebacks is an unusual strategy which for-profits do not use. That is, they sell the property underneath a hospital or nursing home and then require that home to pay rent through a lease, a long-term lease, and they take the proceeds of the sale and pocket the money. They use it for dividends for themselves and their investors. And the hospital, as a result, net revenues fall, and it's more financially unstable. And if the provider goes bankrupt, private equity walks away. So the government, in turn, pays about 60% of the healthcare costs. So a case example is nursing homes. This is a gold standard study where the authors looked at some 18,000 nursing homes over an almost 20-year period. They looked at for-profit homes and then those that became private equity owned. And what they found is that the mortality rates in the private equity owned homes were 10% higher. And in this study, that meant 23,000 more deaths. The Medicare billing was 11% higher. The frontline nurses spent less time with patients, and the homes used 50% more antipsychotic drugs in order to offset the lack of staffing. This is something that is occurring in many other chains, and there are a number of other studies that show the negative impact of private equity on nursing homes. Let's now look at hospital case study. This is a Massachusetts chain that in 2011, a private equity firm bought out 6 Catholic hospitals. And I will call the name of the chain National Healthcare. The private equity firm complied with a Massachusetts Attorney General's requirements that they do things like charity care, et cetera, in order to turn the nonprofit into a for-profit chain. But that agreement ended after 5 years, and immediately the private equity firm sold all the hospital property underneath those hospitals. And it gotten in place, it got $1.25 billion, and it paid itself and its investors $500 million in dividends. Now, you could have used that money to improve operations, to improve new technologies, et cetera. It used it entirely to profit for itself. And then the hospitals were saddled with long-term leases on inflated rents. One of the hospitals was turned into an emergency room. Another one is facing bankruptcy right now. Then in turn, the private equity firm used National Healthcare to buy out helter-skelter hospitals across the country, many of whom were debt-ridden, from other private equity firms. So they were kind of horse trading among each other. And then in 2019, this company's Massachusetts hospitals were the worst performing financially in the state, had higher than average patient falls, infections, patient and readmissions, and vendors were not paid on time, doctors' autonomy was constrained. And then in 2021, the private equity firm wanted out, so they sold the system to the CEO and the real estate investment trust. The private equity firm made $700 million pure profit. The whole system was loaded with $335 million in debt. And the National Healthcare only avoided bankruptcy because of government COVID bailouts. Right now, it's teetering on bankruptcy. There's no real surety of what they will do, and the real estate investment trust is also teetering. So that is a good example of the process through which wealth is extracted using a private equity model. And then one more example is private equity firms in surprise medical billing. There were 2 large physician staffing firms that took over the market, 40% of the market of outsourced emergency rooms. They did so because they could charge out-of-network bills because they were not covered by the hospital's insurance contracts. And in January 2022, the federal ban on surprise billing went into effect. Their business model was premised on outsized bills. And as a result, they could not pay their debt load that they had loaded on the staffing firm. One of them went under, bankrupt in just this year, 2023. And now there are thousands of healthcare professionals who've been laid off, and we don't know what will happen to them. Okay, so let me move to the end. The implications for global health. while we've seen the growth in the US, we've also seen substantial growth in global private equity funds abroad. And here you see the growth, and this is North America, Europe, but substantial growth in Asia. So private equity funds are now penetrating the healthcare systems of emerging markets and developing countries around the world. And we worry about the same things that have happened in the US happening in these countries as well. So let me close with my conclusions. I believe that the healthcare effects of private equity are first that they redefine healthcare from a social good to a financial asset to be bought and sold. They extract outsized returns in a short time period. They use cost-cutting and financial strategies that undermine patient care, healthcare jobs, providers' stability. And they, the macro effects are that the wealth extraction occurs at taxpayers' expense. They accelerate consolidation and monopoly power in local markets. Their financial strategies are mimicked by nonprofits and for-profits that need to try to compete with these systems. And finally, the global implications are that most countries' healthcare systems are in financial turmoil. Private equity firms are hidden, unregulated, opportunistic actors, and they are increasingly buying up healthcare in vulnerable countries around the world. And I'm going to stop there.
Thank you. I want to quickly go to our last speaker, Steffi Woolhandler.
Okay. Hi. I have, these are my disclosures. Now we're going to talk about who ought to own health care and what their goals ought to be. In a bygone era, doctors were really in control of healthcare, and we were are motivated by a mix of altruism, professional and social norms, and let's face it, financial gain. In the ascending model, investors own healthcare and they seek only financial gain. And we need to be building toward a future in which communities, patients, and caregivers together own and control the healthcare system. The effects of commercialization are actually starkly evident in the United States since 1980, when the commercialization of healthcare really accelerated at the dawn of what we call the neoliberal era, also known as sort of Reaganism or Thatcherism. U.S. life expectancy, shown in red at the bottom, began to lag behind life expectancy in other developed nations, shown in gray, and by 2021 was more than 6 years shorter than life expectancy elsewhere. Part of this has been worsening in control of chronic diseases like blood pressure, where control was improving for decades, but over the last decade, we've seen deterioration of blood pressure control at the community level in the United States. The situation for Black and Native American folks is worse, though even white Americans live much shorter lives than people in other nations, shown as the dotted line at the top. The U.S. has diverged from other nations in another way since 1980 under neoliberal regimes. Healthcare costs in the United States, shown in light blue, have diverged from those of other developed nations and are now nearly twice that amount on a per capita basis. We've seen the delivery system itself increasingly come under for-profit ownership. Even hospices are now majority investor owned in the United States. But hospices are not unique. At multiple levels in the delivery system, investors have come in and have taken over ownership and control of our health delivery facilities, with the important exception of our general hospitals, which are still mostly operated on a not-for-profit basis. Private equity, I'm not going to go into other than to say that that's just an acceleration, a very malignant acceleration, if you will, of a trend that's been brewing since the 1980s. The irony is that this commercialization of our healthcare system has been driven by increasing taxpayer funding, increasing public funding. In this slide at the top in blue, I've graphed total spending per capita, public and private in other developed nations. And for the US, I've shown public spending in yellow and private spending in orange. And I do want you to look at where that yellow line ends, meaning that Americans are already, through our taxes, paying the full cost of the healthcare systems, public and private, in nations like Switzerland or Germany. And then we turn around and take additional thousands out of our pockets to pay privately. For this money, we are not getting more physician visits. The US is in yellow on these slides. We're definitely not getting more hospital care. What we are getting is more bureaucracy like insurance overhead. Put at a human scale, we've seen some growth in the number of physicians over the past few decades, but massive growth in the numbers of healthcare managers and healthcare administrators. To use the rather graphic language of the late scholar David Graeber, these are really bullshit jobs. It's a job which is so pointless or even pernicious that even the person doing the job secretly believes that it shouldn't exist. This was a best-selling book of his, Bullshit Jobs. Real jobs produce positive social value, whereas bullshit jobs produce mere market value. Now, even our so-called private sector, like our private insurers, are increasingly reliant on public payers. A lot of this, a big chunk of this is the Medicare program for the elderly, the Medicaid program for the poor, which increasingly relies on purchase of private insurance for enrollees rather than direct public provision of insurance. We've seen with the Medicare Advantage program, the privatized Medicare plans, tremendous enrollment growth where they now cover about half of all Medicare beneficiaries, despite the fact that we've known for decades that Medicare Advantage raises costs to taxpayers. Medicare Advantage, shown on the right, have lower medical costs, shown in blue, but because of their high administrative overhead, actually cost more for the taxpayers. This is in bringing this up to current day, the overhead's about $2,000 per enrollee that the private plan just takes for themselves. And we have to compare that to the overhead of traditional Medicare, which is about 1/10 as large. Consequently, a Medicare paid private plans over $500 billion more than enrollees would have cost in traditional Medicare. And going forward, as Don mentioned, we're going to see a whole lot more of this waste of the taxpayer money. We've also seen the emergence of what I call healthcare mega corporations, what economists would call vertically integrated firms that control multiple levels of the health system. Number 5 on the Fortune 500 list, the largest U.S. corporations. Number 5 is United Healthcare, our nation's largest health insurer, covering 50,000 people. But through their Optum division, they own providers. They are the largest employer of doctors in the country with over 70,000 practitioners. Giant data analytics firm that analyzes healthcare claims data and figures out how to better create profits. And a giant pharmaceutical benefits management mail order pharmacy that dispenses 1.5 billion prescriptions annually. But they're not alone. An even larger company, number 4 in the Fortune 500, is CVS Aetna. They own over 10,000 nearly 10,000 bricks and mortar drugstores, a giant pharmacy benefit manager, a major U.S. health insurer, previously known as Aetna, major insurer. They are moving big into primary care, placing clinics in over 1,000 of their drugstores. They recently purchased a chain of primary care clinics, Oak Street, actually, and they also purchased a major home visit company. And the number 2 in the Fortune 500 is Amazon, and this past year they also moved big into healthcare, purchasing a chain of for-profit primary care clinics, starting a giant telehealth business through their Amazon app, and obviously selling medical products and drugs. I wish I could tell you that all we needed to do to fix this was to turn things back over to nonprofit hospitals, but that's no longer true. Our nonprofit hospitals have really begun to misbehave. Many of them have caused scandals by suing patients who are too poor to pay their medical bills, including Johns Hopkins Hospital, really an important U.S. academic center, but they were suing their own employees who sought out medical care at the hospital and were unable to pay their bills. Additionally, most of the major hospital systems, including several that I've worked with, are now doing joint ventures with private equity, purchasing private equity and hedge fund investors, and becoming increasingly commercialized in the way they approach medical care. There's no longer an option for us as physicians to say we're going to be non-corporate. The pandemic really accelerated the collapse of independent practice and the move into corporate employment. And currently, only about a quarter of U.S. physicians remain in any sort of independent practice, and that number is shrinking. So what we've seen as what I would call financialization of the entire healthcare system. Money has become the mission. Traditionally, providers invested money in buildings and equipment in order to produce medical care. That was our service mission or our social mission. Now, financial entities are investing in medical care to produce money through profit, and money is their mission. And that's really fundamentally what's wrong with the U.S. healthcare system today. This is happening despite the fact that the majority of the American people do not want this. Polls continue to show that the majority of the American people say they want a nonprofit, single payer, Medicare for all system for the United States. And certainly we need to do that to transform our insurance and payment system into a public system through a single payer Medicare for all reform. But in addition, Medicare for all is not enough. We need to address ownership, and we need to take back the hospitals, the community resources, the doctors' practices. We need to take them back from investors and return control to communities, providers, and to patients. And I'd like to close with something that first appeared in the Lancet more than 50 years ago, the famous inverse care law by Julian Tudorhart. The availability of good medical care tends to vary inversely with the need for it in the population served. This inverse care law operates more completely where medical care is more exposed to market forces, and less so where such exposure is reduced. The market distribution of medical care is a primitive and historically outdated social form. So I'm looking forward to your questions.
I want to say thank you to all the panelists. We have a lot of questions. We'll never get to them all. There is a recurring theme, and so I'll try to get to that. And but mostly, I think we've obviously struck a nerve with our audience. People are horrified by the information and are looking for a solution. And so I'll start with, is there any prospect that the United States could have a progressive legislature and administration that would support a healthcare financing system exclusively devoted to the public service of universal patient care rather than being devoted to private wealth? And that comes from Don McGann.
Absolutely, there's that possibility. Other nations have succeeded in establishing nonprofit, publicly owned, sometimes certainly publicly regulated and publicly administered healthcare systems. If they can do it, we can do it. It's just going to take a lot of organizing and a lot of educating the public about the possibility.
I'll add that, Dr. Fegan, that we are the outlier. Every other country finds a way to guarantee care to everyone, every other developed country, and at a cost about half of ours. So no one can say it can't be done. It's a matter of will, and I fear nowadays it's a matter of political will. And one of the other questions was about how the public isn't aware of this. How can we make the public more aware of how distorted things are today and how much better they could be?
I'll follow through on that, Don, because one of the questions for you was why CMS hasn't stepped in to take some action against these entities that are so deeply entrenched into our healthcare system now.
Follow the money. It's Citizens United and the power of concentrated wealth in our political system through donations to Congress and people running for government. That's one of the root issues. These don't serve many people very well. The vast majority of Americans would be better off with the changes Steffi's talking about. However, the vast majority of lobbyists would not. So this is a consequence of the political influence of money in American politics, and it's extremely hard to break. I would tip my hat to CMS. This year, for the first time, CMS issued regulations, both implementing regulations allowing negotiation of drug prices. Never been done before. It's slow, but it's a start. They also issued regulations that begin to tamp down the coding games I was talking about in Medicare Advantage. We'll see. They're sticking their necks out, and we will see whether they're able to do that without being shut down. And of course, I have to say the upcoming presidential election could not be more important with respect to the issues we're talking about.
It is huge. And Rosemary, someone asked if you could address the financial regulations that make it possible for private equity to extract the profits, including the tactic of selling and leaseback of property. Although I think Don alluded to the political forces that make this a challenge.
Well, so first of all, private equity emerged in part because of the deregulation of financial sector in the 1980s, 90s, and 2000s. And as that deregulation occurred and allowed more unregulated capital to be used, the private equity and other financial actors have virtually no regulatory oversight. And so this is government actors, Congress and regulators, making those decisions to allow large pools of unregulated capital to kind of move around the economy. And so that has created this opportunity for financial actors like private equity to do the kinds of things they're doing. And they, for example, do not have to file the kinds of financial reports that the publicly traded corporations have to file with the SEC. So their world is not transparent, and there has not been the political will to rein them in part because I would argue there is a kind of capture by, we see, for example, former government administrators high up from Democratic White House staff going into private equity when they get out. So there are many people across the board who view private equity as a good thing, as creating market efficiency, as Don was saying. And so they think it's cool, it's creating market efficiencies, and there is not the political will to rein it in.
So we also had a question about, and I think Rosemary alluded to it, that this is a phenomenon that is spreading not just in the United States. And one of our neighbors to the north asked if we had advice for Canada, where there seem to be conversations about privatization and whether this is a better way to deliver healthcare.
I'll start. You're playing with fire. You're just playing with fire. No healthcare system in the world functions exactly the way we all would wish it would. There's trouble right now in the National Health Service in England, about the same as ours, but because there's an accountable government offering guarantees, or in the case of the National Health Service, National Health Insurance, there's someone to point your finger at. And so magical thinking can begin. And, if we let the market in, things will go better. Find me the evidence. I don't see it. And I think, I hope someone asks me for advice, because my advice will be very clear.
I'm trying to go through so many questions at the same time. But, Henry Kahn points out that healthcare accounts for only a quarter of the excess deaths that we have in the U.S., and that it is the non-medical social issues related to poor housing, poor diets, failed educational systems, and that these societal issues reflect some racism that we have as a country, and that fixing the greed of the medical system is necessary, but we also have to look at, can we comment on how we address the greed that has infected all of, or so much of the non-medical sector of our society.
Well, I mean, part of addressing inequality and greed is addressing it in every major sector, and healthcare is obviously a major sector. It's a major employer and a major economic force as well. So I agree with Dr. Khan, we need to focus on other things as well. But most of us work in healthcare, and we need to fix the part of it that we work in and that we have some control over. And right now, it's really not working in the interest of our patients or communities.
Yeah, so
Dr. Fegan,
go ahead, Don. Please.
There is a generic point here. I agree with Steffi, but I also agree with the question. We have a whole bunch of problems that will only yield to collective action, to us agreeing to do things together. The big one on my mind, of course, is climate change, which is, by the way, a healthcare problem. The World Health Organization says climate change is the largest threat on the planet to human health. Yet we're having trouble mobilizing the energies, and the incumbents, the status quo incumbents, the same people Rosemary's studying, also have a grip on the steering wheel toward decarbonization, and it's not going well. I think we could, and I think poverty alleviation is another example of collective good in which poverty in a society doesn't benefit anyone in the society except a small number of people who exploit it. And so we have, I think we, to raise the stakes a little, we actually have to have a big conversation in this country about how we engage in absolutely needed problem solving when the commons is at stake. I don't know if you agree with that or not, Steffi.
Yeah, I do.
I think that it's a huge opportunity for us to focus people on the dangers of using profits to dictate public policy. And I think that's a huge part of what we've been talking about today, that we have, foregone our commitment to society as a whole for the benefit of a few who profit from these systems that are so dysfunctional to serving the needs of the public as overall. So I think we're running very close to the end of our time, and a number of people asked about this information that we provided and the slides, and it was said at the beginning, these people who registered for this conference will receive the opportunity to play back on demand the content. So it will be available to all. I want you to know that this is one in a series that we will be presenting a seminar on November 2nd about rethinking care for the severely mentally ill. And we hope that we will have as much interest generated. This is a dense subject, and we try to get as much as we could within all too short a time period. But I'll give the panelists a chance for one last comment before we sign off.
So I'll jump in just to say one of the solutions that is minimal, but it would be a good start, is to have the Medicaid proposed rule that 80% of funding go to staff, to have that apply across all healthcare institutions. And we have examples of nurses getting a minimum staff to patient ratios in California. Now there are several other states. That's a very transparent metric that can be used immediately to then cut off the low road, to cut off the amount that is extracted.
Yes, Steffi and then Don.
Okay, well, I do recognize some of the names in the question and answer, not most of them, but many of you have been doing this kind of activism and educational work around improving the healthcare system for a long time. But we need to keep doing that. We need to increase our work, and we need to remember that the needs of our patients are really not being met Certainly, big insurance companies aren't very popular. Giant corporations aren't very popular. People are very concerned these days about inequality. So we have some real opportunities for moving forward to a much better healthcare system through our continued work and activism.
And thank you. And Don, one last word.
Anyone who thinks that we can solve these problems without political activism, I think, is wrong right now. This has become political. The incumbent's power is immense, and only political activation is going to allow us to change in the direction of meeting patients and community needs.
Thank you all, and thank you for joining us.